If you're in fertility treatment and wondering, should I keep going or should I be considering donor eggs? This episode is for you. Today, you're going to meet Dr. Maureen Moomjy, and she's going to walk us through everything that you need to know to make this tough decision. We're going to be talking about three things. Number one, how do we understand IVF and why it fails even when everything looks normal? Number two, we're going to be thinking about how many tries at different ages should I reasonably expect before I consider donor eggs? And number three, we're going to start thinking about when is donor eggs the right option versus the only option. We're going to sort through everything that you need to know and give you clear, research-based information so that you can have a great conversation with your doctor about this very important topic. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. Today, I'd like to introduce you to Dr. Maureen Moomjy. She is a lovely person and a fantastic doctor. She's a reproductive endocrinologist and fertility specialist with a lot of history and a lot of experience in many areas of fertility. And although she is connected with NYU Langone, she runs her private practice in a very thoughtful way. And so I thought she would be the perfect person to help us because we really need to understand how this donor egg decision-making process works from a reproductive endocrinologist. You've heard me talk about it a lot, but it's so confusing. And I know that you get scattered information from Google and on the internet. So today you're going to meet somebody special who's going to help you and walk through all the things that you need to know as we move down this path. Thank you so much for coming.
Thank you, Lisa. Thank you for that very kind introduction. So it's great to be able to chat with you today, and this is such an important topic.
Yes, so important. So why don't we start at the beginning? As we start to think about fertility treatment and IVF, what are the first things that people have to think about if they might be a candidate for egg donation?
So I always say that it's a very nebulous journey, the transition from IVF to donor egg. It is not a black and white moment. And there's not a line in the sand whereby, IVF ends and donor egg promptly begins. For most people. Now, there are certain people where donor egg is pretty much the only option. They shouldn't be or are not candidates for IVF. And that's a very small portion of the people who actually subsequently go through egg donation and have successful pregnancies. So that group where donor egg is front row center for them, people who had some sort of major surgery whereby they lost both ovaries, or major cancer treatment, radiation to the pelvis, and the ovaries have clearly stopped functioning. And there's even people who were born without ovarian function. You can see ovaries on the ultrasound, but for some rare genetic reason, they are just not working. Won't respond to medications. So these are the small portion of the people. But I add to that people who are 45 years old and they don't happen to have any frozen embryos that they can utilize. 45-year-old women should not be wasting their time in IVF. We have a lot of internal data collected over more than 10 years trying to compare every age group separately year by year. So when we do national statistics, we're submitting for 42 and above, as a group. When we do our internal statistics and, working with the NYU Fertility Center, we have enough patients that we can do statistics every year and generate information. We have done statistics specifically for 40-year-olds, 41-year-olds, 42-year-olds, each year up to 47-year-olds. And it was about 15 years ago when we decided that the pregnancy rate in IVF for 45, 46, and 47-year-olds was less than 1%. And many, many years, it was 0%. So 42 and above is a little bit of a misleading, statistic for the national organization to use for statistics because If you're 45, you're like, yeah, I'm in that group. I'm 42 and above. But it's really 42 and 43-year-olds in that group, maybe a few 44-year-olds. So when we ran these statistics and realized that, 45-year-olds were either not getting pregnant 99% of the time or having miscarriages, we decided it was just unfair to offer IVF for 45-year-olds unless something clearly new and different comes along. And honestly, we haven't had that wonderful moment where something clearly, advantageous for the 45 or 46-year-old has come along. And so while there are many centers in this country where they don't have those statistics and they just let people do IVF no matter what the age is, when you hear that someone is a celebrity and they're 52 and they have twins, it's unlikely it's their own eggs, because if it was
Right.
their own eggs, they probably would have gotten pregnant at 44. So it's probably egg donation, which is very, very successful for the women who end up utilizing it. So the main group who ends up utilizing donor egg is typically women. The average age has always been about 43. It's never anybody's first choice. Okay. It's often not your second or third choice, but it's good to know that it's available because it's made countless people happy families in this city, in this country. And the majority of the people who are availing themselves to donor egg are women in their 40s who have failed IVF, and they've done often 4 or more cycles of IVF and they're not getting pregnant, or they've done 3 cycles and they're not even getting a normal embryo. So when you keep cumulative statistics, so seeing what happens when someone does more than 1 cycle, okay? When we keep cumulative statistics, if we see that someone's gone 3 full IVF cycles without 1 single normal embryo, that's highly unusual in our day and age. And that means that that person really does have an ovarian problem and really does need to at least start the conversation about egg donation.
So just to walk back for a second, so we have some framework to understand it, and these don't have to be hard numbers, but how do we see different age groups and their success or possibility for success with IVF at different age groups?
IVF has an age factor, and some people know that and some people don't. Some people think, oh, if this doesn't work, I'll just do IVF. But IVF has an age factor.
Yeah.
So the success rates for women 35 and under are very similar. You can generally get a reasonable egg and embryo yield in most women, unless there's, again, a very significant ovarian problem. For women 36 to 38, the overall IVF success rate drifts down like maybe 5 percentage points per cycle. And when you get to 40 versus 45, getting back to that original data that we ran for about 10 years, we were seeing, a cycle of IVF. It was sort of easy to remember. The 40-year-olds had about a 40%, pregnancy rate. But then it dropped down 5 points for every year. So 41-year-olds were 35, 42-year-olds were like 28, 43-year-olds were like, 18, and 44-year-olds were about 5. And then, as I said, 45 and above was 0 to 1%.
So it really changes dramatically as you get older.
40 to 45, every year is a different year, and every 6 months matters.
Right. So when we think about moving in that direction and what helps people, it sounds like the best thing for people to do is have their workup as young as possible and start fertility treatment as soon as possible. But for a lot of people, that's difficult because, as you said, they think, well, I want to try everything else first and put IVF on the back burner because it feels like taking out the big guns and it's overwhelming. But beyond that is donor eggs, and people would prefer not to go there. And so, how do you encourage the women that you see to start that process, to move, let's say, from maybe they're, 36, 37, 38, to move from going from trying at home to trying with IUI and then moving towards IVF? That must be a difficult decision.
It is. I actually have a chart in the office for the phenomena called aneuploidy and how it relates directly to age. It's a chart that people get. They take pictures of it all the time to really absorb it when they get home.
Mm-hmm.
But aneuploidy means wrong number. And aneuploidy is the main determinant of whether we have an ongoing pregnancy or we don't. So what it means is that it's very specific to obstetrics. And the egg that you ovulate today is the egg that you were born with. So I would say it's not a great design. If I was in charge, I would have designed it absolutely differently. But the design is that women are born with a cohort of eggs and there's no renewal process.
Yeah.
Sperm renew every 3 months. Every cell in your body has a renewal process and eggs don't. Either they ovulate or they absorb. And the absorption rate is about 10 eggs per month, and the ovulation rate is about 1 egg a month. So that's something that most people don't know or appreciate. And I always say that IVF in general helps you benefit from eggs this year that you were more likely to absorb than to benefit from. The approach in IVF is to work with a group of eggs, ideally, 15, 18, 20 eggs whenever we can, because they're not all mature, they don't all fertilize. They don't all grow into healthy embryos. And once they do grow into healthy embryos, some of them have aneuploid. So getting back to that concept, the egg that you ovulate today has been resting very comfortably, very dormant, doing nothing. Okay. It's a very large cell. It's like more than 1,000 times larger than a sperm. Okay. And it has to do all the precision chromosomal work. It actually has twice the amount of chromosomes that it really needs. So it has to reduce its chromosomes. It has to release a quarter set of chromosomes when the egg matures at the time of ovulation. It has to release another quarter set, hopefully within a day when the sperm penetrates the egg. And now the egg has gotten rid of a half set and the sperm is bringing in a half set, and the remaining half set of the egg and the sperm now unite and make a new whole set. This does not happen with any other type of cell or tissue in the body. And so the egg is susceptible to making errors. It, lines up the chromosomes, it pulls them apart so that it can get rid of a quarter set. And lo and behold, one of the chromosomes didn't pull apart. And now you have an extra chromosome either in the embryo or it got expelled as a whole chromosome, and the pair that, the single chromosome that should have stayed in the egg didn't. So either the egg is missing a chromosome or has an extra chromosome, either way. And now the sperm penetrates, but we still have that extra chromosome, more or less. And those are the main reasons for Down syndrome. So Down syndrome is an extra chromosome 21. We all know that Down syndrome goes up with age. The other chromosomal imbalances are usually miscarriages. So we know miscarriages go up with age. We hopefully know that it takes a longer time to conceive as you are working on your second child versus your first, or your third child versus your second or first. And what's going on is that some of those cycles, there was aneuploidy and the body recognized it and didn't let it implant very long or didn't let it implant at
Right.
all. So aneuploidy is going up with age. And again, very similar to the age, it kind of goes up like a straight line from 40 to 45. It's almost 100% for 45-year-olds. But if we look at embryos, how many, if we take IVF data where we're actually testing embryos and looking for aneuploid, we're going to see that for women in the 30-ish age group, about a third of the embryos are aneuploid, but they're making a nice, typically, egg yield, embryo yield. There's going to be normal embryos in that group. But when we get to 35-year-olds, about half of the embryos are aneuploid. And when we get to 40-year-olds and 41 and 42-year-olds, 80% of the embryos are aneuploid. So this is our limiting factor. IVF does not have a treatment for this. So what IVF does is just it looks to work with more eggs and embryos to find the normal one. And if we're getting into a situation where egg yield is going down, which is what happens with age, and aneuploidy is going up, which happens with age, then you could have many of the patients in the older age groups just not getting a normal embryo from their entire cycle, which is very disappointing.
Yeah, very disappointing. And with regard to that, just to kind of go back to comparing with sperm because men can make lifestyle changes, right? And then come back a few months later and their sperm can be better. And women can't really do the same thing. And yet, there's a lot of information on the internet about changing your diet. And certainly, there's some conditions, obviously, like PCOS, where you would need to think about that. But generally speaking, changing your diet, microplastics, all of these things, and how that will improve your egg quality. And I think for many patients, they want to believe that. But you're fighting against time, right? And then how our genetic material works. So, how realistic do you think it is for patients to start to think, well, if IVF is not really working for me because I'm not in a situation where my embryos are in good shape, so, I'll just change my lifestyle and that should help my eggs?
I wish that there was a supplement that would clearly improve egg quality and reduce aneuploidy. And quite honestly, we don't really have that.
Mm.
There is some data for CoQ10 because that helps the little mitochondria or the little organelles that create energy for the egg cell. And the egg cell has a lot of mitochondria. So, yes, I vote yes for CoQ10. Honestly, anyone doing IVF, one with each meal, but start the month before, keep it going until you're happy with your embryos. Certainly, there is data to say that smoking reduces ovarian reserve.
Wow.
Smoking anything. So, my message to every single, female is just stop smoking, vaping, smoking marijuana. Just stop all of this because it's not helpful for your ovaries. Okay. I've tried to find data on like whirlpool, hot tub, things like that, but nobody's going to have data on how does that impact your ovaries. But we know it impacts your sperm. So
Yes.
I always have this question mark, and I'm hesitant for anybody to be using, heat treatments if they're trying to conceive because it's missing information. But it is a question mark. But as far as these long list of supplements that are on the internet and on social media, I mean, honestly, they're being advertised and they're being sold by supplement companies. And so, if there's not data, I don't look to turn someone's life upside down and I don't look to mislead them because they could lose valuable time, thinking that these supplements are clearly going to help. Now, I do check all of my patients for their mercury level. Interestingly, mercury is a bigger problem than we think. Sushi looks so healthy,
Yes.
but everything in moderation. And so if people are having sushi every week for 52 weeks of the year, interestingly, the mercury can be elevated and the mercury is not good for, ovarian function. So I check everyone. And then once someone does happen to have an elevated, we get them to adjust the diet accordingly, focus on small fishes or shellfishes, but to really avoid the large fishes. Salmon, however, is okay. Then we repeat the mercury level in 2 to 3 months and might repeat it in 6 months, make sure it stays in the normal range. Petite women seem to have a harder time metabolizing mercury. I find a lot more of them have elevated mercury levels. So, those are sort of the lifestyle things that I think about, but there's no other supplement or, lifestyle change that is going to have a significant impact on how one is doing in IVF.
And what about other things like changing your diet and having, more of a whole foods diet and reducing dairy and gluten and all of these things? Do those things have any effect?
Some people have an inflammatory reaction to dairy and gluten, and that may impact implantation because inflammation is not good for implantation. But a gluten-free or dairy-free diet is not going to change ovarian function or your ability to get a good egg or embryo yield.
So time is really the biggest predictor.
Yes. I mean, and most people who come to IVF are already in a healthy lifestyle. They just are. But we go over, these pertinence in a visit to make sure that something wasn't overlooked. And, when someone really has one or two IVF cycles where embryo yield has been unexpectedly poor. Like, let's say we had 12 eggs, but 9 fertilized, and we would have expected 4 maybe good quality embryos on day 5, 6, 7, and we got 1 or we got none. Those patients actually are candidates for what a protocol involving growth hormone as an IVF adjunct. Now, the problem with growth hormone as an IVF adjunct is we don't have randomized control data, and we probably never will because those type of studies are expensive to run, and a lot of patients don't want to be in the placebo group.
Of course, yeah.
But there is some, a fair amount of, prospective data or cohort data to say that some people do benefit. The reality is it's not a guarantee of a better cycle, but for those patients who clearly have a lower embryo yield than their egg yield or age would predict, I would say about 30% of them do better with a growth hormone added to their stimulation, to their IVF stimulation. But it isn't going to reduce the aneuploidy rate, but it may help you get 1 or 2 more embryos so that, it becomes a numbers game. If you have more embryos, then you're more likely to find one that's normal. But it doesn't, if you take a 45-year-old and give her growth hormone, I don't think she's going to get, a healthy embryo.
Yeah. It's not going to make her 20.
Correct for aneuploidy itself. It's going to help those people who have, some difficulty with egg to embryo progression to make that egg to embryo progression in a more typical fashion.
As they're considering all of these things, your plan would be, if they're still struggling and they want to use their own eggs, the next thing would be to try some of these, either the supplements, the CoQ10 or the growth hormone, to see if that works.
Yes, again, if the IVF cycle overall suggests that it might work, it's definitely not going to work for everyone. If someone's making 1 egg in IVF and they're 44 years old, they really need to think about donor egg. They need to start having those discussions.
Mm-hmm. And what about using testing like PGT ahead of time? And, before you get close to having lots of failed cycles, where on the continuum do you start to kind of think about that?
Well, I'm in favor of PGT, honestly, for any cycle.
Oh.
The value of it is that it focuses your embryo selection. So you're not going to waste time on an embryo that wasn't meant to be. And there's always abnormal embryos in every IVF cycle.
Mm-hmm.
It is so rare, unless someone is like PCO, 28 years old, wasn't able to have a safe cycle without IVF. You're doing the IVF for safety. Yes, I had someone, this week who had an amazing amount of, euploid embryos. The majority of the time, it's going to follow those statistics, whether if you're in your 30s, young 30s, it'll be like 1/3 of the embryos are not normal. And if you're, 40, it's going to be 60% of the embryos are not normal. So why waste your emotional energy on a full frozen embryo transfer cycle on an embryo that looks good? It met criteria for biopsy, but it didn't get biopsied. You didn't get the PGT information. So you're transferring it. And if it doesn't work, you're blaming yourself. And you wasted, another month.
Yes.
So I find that with PGT, there's a quicker time to a healthier pregnancy. There is a lower miscarriage rate for, really everyone 34 and above. And it certainly gives us great comfort in just doing single embryo transfers, which is all we have done for almost 20 years,
mm-hmm.
plus the PGT. So, it has a lot of value.
Yeah.
Yes, sometimes it has a 98% accuracy rate. It's not 100% accurate. So you are still going to evaluate your pregnancy at week 12 like everyone else. But if you can lower the miscarriage rate for someone who's already in IVF, people just don't wake up and start doing IVF. They've had, a fair amount of aggravation with,
yes.
Delay of pregnancy.
Yes.
And so they've already been on a long journey. And, a miscarriage is a huge hassle because it's 2 months to diagnose it, a month or 2 to recover from it. All of a sudden you're out of loop, and you add the month that you did the frozen embryo transfer cycle, you're out of loop 5 months.
It's a lot.
I think that the PGT has value. Now, there's people who debate it and they say, well, it doesn't raise, cumulative pregnancy rates at the 1 year mark. That may be, but it certainly lowers aggravation and miscarriage, rates. So,
Mm-hmm.
and
Mm-hmm.
then, if someone's doing PGT and they've had 3 cycles and none of the embryos have been normal, that's significant information that can really help that patient maybe accept that it is, in fact, time for egg donation.
If you're watching this episode, chances are you've been surfing the internet, going through Google, looking at all sorts of websites, and trying to piecemeal information together to get the answers you need. And that's exactly why I created the Building Your Family community. It's the only expert led platform created for people who are using fertility treatment, surrogacy, or donor conception. Inside, you will find all sorts of information on all of those topics, including early parenting. You can find the information in the show notes. And although this will not replace your doctor, it will help you make really good decisions. And it will also help you feel less stressed. So I hope to see you there. As we move on the continuum, and I think, both seen lots of people who range from, I could never use donor eggs. That's not for me. I would rather live child free. And then people who will consider it, then people who will jump into it fairly quickly. And then people who, the moment you mention it, say, okay, right? So you have all of these people and they're going through fertility treatment. And some of them might say, well, I'm in the group that I don't want to have ever use donor eggs. If I can't use my own genetics, that's it for me. So for those people, they might say, well, why do PGT anyway? Because it's not, it's a pass fail system and there may be some embryos that could work. So maybe for me, if I'm not ever going to use donor eggs, maybe it makes sense not to use PGT. What do you think about that?
Well, if you have a miscarriage and you just lost 5 months and you're 40 years old, that's an important amount of time for your next IVF cycle.
Yes,
And there are people who just don't come back because the emotional roller coaster ride is not worth it anymore.
that's right.
I mean, if someone's going to do IVF donor egg and they choose not to do PGT, that, I think is a reasonable option because the aneuploidy rate is lower. It's interestingly still about 30% for egg donors, but it's certainly not 50 or 80% like it is for older women. To reduce the miscarriage rate to me is priceless.
Yes, yeah. It makes a lot of sense. But I know there's a lot of, controversy about that because some people say, I'll take an embryo that was kind of in the middle ground or a mosaic embryo, and I'd rather transfer that and take my chances because I only have so many embryos or so much money to keep going or whatever it might mean.
Well, my approach to this PGT testing is that on the day that the embryo is biopsied, in order to get the 5 to 8 cells that can be sent to the DNA testing lab, on that day the embryo is frozen. Nobody knows what the chromosomal result is. On that day, the couple, or if it's a single woman, is the only person who can make decisions about that embryo. And she has full autonomy. If she wants to transfer a mosaic or a segmental aneuploid, which we call, these are variant embryos, we can actually quote what our experience is on the overall pregnancy rate by looking at the variation in the embryo. And some of the, like a low-level mosaic might implant 50% of the time instead of 60. But a high-level mosaic, which more than half the cells are abnormal, might implant 10% of the time. But I have had fine human being babies on variant embryos. But then there's women who, had a terrible, birth defect and detected at 16 weeks in a previous pregnancy, and they only want the top embryo no matter what. Their prerogative. It's their
Yes,
embryos. So they choose what they want to transfer. We make sure that the lab reveals all the possible information with the PGT testing. We
that's
don't,
great.
mask any of the information. And we have genetic counselors who are available and very responsive to the patients to give them the exact data for the exact embryos that they have found. For me, my patients have full autonomy on how they choose their embryo transfers. While a patient may transfer a full aneuploid, so all the cells came back abnormal, the chance of that being normal is tiny.
Mm-hmm.
I haven't had any patients choose to do that. I think,
Mm-hmm.
realistically, it's just such an uphill phenomena.
Right.
Okay. But I've had many patients transfer mosaics and segmental aneuploids, and they're willing to accept. And we don't see an increased risk of birth defects, interestingly. It's more of an all or none phenomena. Either they implant or they don't, or they miscarry or they don't.
Right.
Okay. So some of this corrects.
On its own.
And we actually don't know how many of us were mosaics when we were implanting.
Well, of course. Listen, when I went through IVF, there was, there's no such thing as embryo testing, right? It didn't
Right.
exist. There was,
Right.
if you were lucky, you got like 5%, and that's transferring 4 embryos at a time. So
It's amazing what an evolution it has been.
it's amazing. It's amazing.
Yeah.
And so when we do think about this, you know, for everybody out there who's kind of thinking treatment's not working, how should I really think about this? And what is my personality type and how do I feel about it? Because you're raising all these important issues that patients have to think about. Could I tolerate a miscarriage emotionally? Could I tolerate losing 6 months, the money, the time, the energy? How much do I really want to use my genetics versus just be a parent, go to parenthood faster? So as you're looking at your patients, Dr. Moomjy, how do you decide how to advise them? Because it's very complicated. Every patient's going to probably have a different timeline for when they can accept donor eggs or not, and what they may want in this combination of choices.
I think what you said previously is this wide variety of how people react to the topic. Some people jump in pretty promptly, and other people adamantly avoid it and choose to be child free. And then there's a whole bunch of people in the middle. But I think that time is incredibly important, time and counseling, which is where you come in.
Thank you.
And really sharing with family members and really sleeping on it and envisioning all possible paths, not just being a parent with a genetically related baby, but envision yourself in the path of, caring for 9 months a fetus that, was created through a donor egg embryo, but you've just carried it for 9 months and you've done all the, nutritional support and all the healthy living. And now you're going into the delivery room and you're going to deliver and you're going to be a biological mother. And then you have the opportunity to breastfeed and envision all that. Okay. And knowing that, when the child's 2 years old, that child has your husband's genetics, but doesn't have your family genetics, but has low genetic risk. And is that something that you could be comfortable with in this very long journey to parenthood?
Mm-hmm.
And then the last path is envision yourself just child free, not having, children. And is that something that you and your partner would be, comfortable with or more comfortable with? And then continue to give it time. I mean, long ago, I had a patient who just, slammed her fist down on the table and said, there is just no way I will ever do donor egg. And then, she was in this, 44 and a half age range. And also her husband had 1 or 2 children from a previous marriage. And she shows up in my office 2 years later. She's like, I'm ready to do donor egg.
Yeah.
I said, well, if you're ready, I'm ready,
Okay, great.
And then she, happened to live near me at the time, and I would run into her and the kids, and she would say, I want to just stand on the corner and tell everyone how great donor egg is. So, it's okay to change your mind because you have to be more sure. And sometimes you're only more sure with time. But envisioning these different realities is important, and to keep doing that and to explore it. Yes, meet with the psychologist, with your partner, meet more than once. Go to podcasts, read information. But you can speak to the reality. I mean, people who do successfully have donor egg families are, psychologically, strong.
Yes, they're doing great.
is what I've been reading in, the literature that I read.
Yes, yes, they've been doing great. There's no question. But as you said, some people just don't want that. And so when you're in your practice thinking, okay, this patient's saying to me, well, I don't want to do PGT. I want to just keep trying with my own genetics, or I want to do more cycles. I want to keep doing more cycles because I really don't want to go to donor eggs yet. And they have all of these thoughts about it, but you feel like they really would consider donor eggs. You might look at it a little bit differently, let's say, than somebody who says, this is never going to happen for me.
I think that, doing IVF cycles makes sense if you're getting an egg yield,
Mm-hmm.
if you're getting at least an embryo, whether it's normal or abnormal, but you're getting at least one embryo from the IVF cycle, and you're under the age of 45. You can do as many IVF cycles as you feel comfortable doing, even if it's an outlier situation, even if you're on the fifth or sixth cycle and we're telling you like the chances of success are 2%. When people are considering egg donation, usually they're not making enough eggs to actually do IVF. And so if someone's only making one or two eggs, and if there's at least one tube open, and there's relatively normal sperm parameters, then I think that those patients are better served with ovulation induction and timed intrauterine insemination. We have data to show that the chances are low with that. They're actually similar in IVF when you're talking about less than 3 eggs in IVF. So they're very similar. Now, of course, you may have someone where they just don't have the sperm parameters to do an IUI, and so be it, right?
Mm-hmm.
But I've had countless people in my practice over the decades who have in fact succeeded in conceiving on their own eggs while exploring donor egg, okay? And the majority of them, it's been in a non-IVF setting because the majority of them are not IVF candidates. They just don't respond well to get a group of eggs together. So yeah, more time might help some people. It's also delaying, a more expeditious route to parenthood. But if that expeditious route with donor eggs is just not something that you can emotionally wrap your head around, then I feel like, ovulation induction with timed intrauterine insemination is really no risk except time. And if that helps someone, some rare people have, a pregnancy on their own eggs, then I'm fine with it.
But there is a time limit, right? There is some time limit because there are guidelines, right, about how old you can be when you use donor eggs too, right?
Well, that's why it's important, like at 44, no matter who you are, what you're doing, to start the discussion.
Mm-hmm.
And the community at large, there's no consensus, there's no true rule, but to try to complete donor egg transfers by the time you're 48 is a goal. Now, of course, if someone had, colon cancer and was in treatment and they can't, didn't get medical clearance until they were 50 to do a transfer, but they
Right.
have medical clearance, we've done it. We've done transfers in the over 48 group, or someone has a 3-year-old donor egg IVF baby at home and they're 49 and their pregnancy was smooth as silk, and they have frozen embryos. We've done that. Okay.
Mm-hmm.
But ideally, if you're taking a transfer at 48, you're delivering at 49. I mean, realistically, you're going to be 69 when the child is trying to graduate college. That's,
Mm-hmm.
you want to be there for that young adult.
Mm-hmm.
So that's
Yeah.
the reason to try to, focus energy and decision making, during these years, 40 to 48.
And what about for the younger group, people who are in their 30s and they're trying IVF and it's not working? Maybe there's just unexplained infertility or some reason that you haven't been able to pinpoint yet, but they're just not making enough good embryos, or the embryos look okay and they transfer, but they don't make it for some reason. What would you say to them? How long do you think they should wait?
Well, this is where PGT is incredibly helpful. If someone has had, say 4 transfers each time of a PGT normal and it does not have an ongoing pregnancy, you can make a case to go to a gestational surrogate, right? Because we know that the embryo should have implanted 60% each time. And we know that by 3 transfers, about 97% are going to have an ongoing pregnancy. So there seems to be a uterine factor there. So that's, again, when you do PGT early on, you're getting the information of, if the cycle's not working, but it was PGT normal, then you start doing deeper exploration of the uterus.
I'd like to ask you a question about that, because we were just talking about that recently, that let's say the cavity looks fine, everything looks okay. And I know there's some people have difference of opinions about this, but there are some guidelines about how thick the uterine lining has to be and all of that. And yet people have ectopic pregnancies, right? So how do we explain that?
So ectopic pregnancies in IVF are 1% to 2%. And yes, we've placed the embryo in the uterus, often with ultrasound guidance. So we place the embryo in the uterus, right? Often with ultrasound guidance. Now, we're not seeing the embryo, we're just seeing the little fluid bubble that the embryo is in, right? That's being pressed into the uterine cavity. But it can float. And it can find a spot that's not where we placed it. It typically will adhere within the next 24 to 36 hours, but it can float during that time. People who are having ectopics generally are going to benefit from removing the tubes if they're having ectopics in IVF. There's some sort of altered fluid dynamics. There can be some chronic inflammation in the tubes. And if it's, undermining the IVF process, that is something to think about. When a patient of mine has had an ectopic, I generally take, once the ectopic is fully recovered and all the hormones are back to normal, I will take a month and we will do a practice cycle where we do the hormone support. But instead of doing a transfer, we're going to actually sample the uterine lining and send it to specialty labs and see if there's any chronic inflammation there that is somehow negatively impacting the embryo to implant in the uterus. And a lot of times there are things you can do, whether it be antibiotics or lupron pretreatment to try to make a better uterine environment.
So there are a lot of things that you could try first. You can take a deeper dive into what's going on before even moving to a gestational carrier, potentially.
Right.
That's great. So at what point do you think that people should consider using donor eggs? And what if they want to continue treatment while they're using donor eggs or exploring donor eggs?
So again, getting back to 45-year-olds and above, if they don't have any frozen embryos, I think that the most medically ethical discussion and treatment offered should be donor egg and IVF. For everyone else, if you have, 4 failed cycles and you're not making that many embryos, and we know that the embryos you made were not chromosomally normal because we were doing the PGT, that's an outlier situation. And that's something that is so infrequent that it means that there is a true egg problem, and donor egg will definitely provide a much more respectable chance at pregnancy, because the donors have to be under the age of 30. They have to have normal ovarian function and parameters. If they had any pregnancies, they have to have normal obstetrical history. Maybe 40% of the women who present to be egg donors are actually passed as egg donors. So there is quite a selection process geared towards trying to get the best possible ovarian function, because this is what we're looking for. Just like if you were donating a pint of blood, if it had a bacteria or virus in it, it wouldn't get past, the collection phase. So, donor egg has that, inherent advantage that people who move to donor egg who have these very complicated IVF histories get pregnant at the highest rate that we have. You take someone who's had 5 failed IVFs and offer her donor egg IVF, she has a 60% chance of being pregnant in that cycle.
Wow, that's incredible. And that's so encouraging.
Fresh donor egg, like frozen donor eggs, it's a little bit lower.
Mm-hmm.
But typically the history is not going to influence the chance of pregnancy unless there's been uterine scarring. Outside of that, women with these very complicated histories and failing IVF are perfectly fine candidates for donor egg IVF.
Well, I think that's really helpful for people to hear because I hear, and you may hear the same thing, people come to me and they're so nervous when they start using donor eggs because they've already felt like they've been beaten up through this process so much and they're exhausted and they can't deal with it anymore and they feel like there's no way it's going to work. Why should it work? They've had such a terrible history. And what they're not seeing is that this is a different chapter entirely.
Entirely. Absolutely. And gratefully,
Yes.
there is actually something very different, very potentially successful,
Hmm.
very psychologically challenging that awaits you if you want to go for it.
Yeah, it's wonderful. And what about those people? Because, again, I think there's so much pressure put on this that it feels like this is just like going from IUI to IVF feels like, the biggest thing in the world. When you go to donor eggs, there's so much pressure that this has to work. The time, the money, the expense, and all the upset from before. And sometimes it doesn't work, right? It's not 100%. And yet there's that expectation, I think, for a lot of people that it could work without question. And so, a lot of the people I see feel very disappointed and shocked if it doesn't work.
It's pretty much with everything. You have to give it more than one opportunity to say it's absolutely not going to work for you. And it is rare, but it's not zero, that someone would not have an ongoing pregnancy with three separate, transfers and egg donation. Unfortunately, we can't control 100% of, fertility outcomes, even in, you know, something strong like donor egg IVF. But considering that the patients going down that path have had quite the complicated stories, they do very well. But yes, you don't want to put pressure on yourself to get pregnant or to expect that you have a guarantee of pregnancy on the first transfer. I do say, we're transferring an embryo. It has 5 or 6 days of development. There's 270 days to go that we do not have, immediate control over.
Yes.
So it is just, important to sort of like zoom out and say, all right, this is a good opportunity. Let's see where it goes.
Give it a shot.
Yeah.
Yeah. So for those people, and, I think we both see them, for those people who feel like, okay, this has been such a roller coaster for me. And now I'm at donor egg. What else can I do? I want to pull out all the stops. I want to take anything I possibly can, or stop taking anything I possibly can, or try anything I can so I can give myself the best chance possible.
Well, this gets back to healthy living. And interestingly, I say that pregnancy is a mini marathon and it's a real cardiovascular challenge. And it is a time to be in your best possible cardiovascular health. And for women over 45, they even have them do like a treadmill test to see how they're doing.
Wow.
And so being in good condition, like, address if there's a weight problem, address it. If
Hmm.
there's a blood pressure problem, get it normal. Like, and I always say you'll never be in better health than when you're doing this. That kind of cardiovascular health really and metabolic health can make a difference for people. So I'm not so much, people, like supplements because you can buy it and, swallow it.
Hmm.
But,
Yes.
healthy, like
Yeah.
exercising for real,
Yes. Right.
3 or 4 times a week is a prescription. People maybe some people are great at it and some people avoid it.
And some people go the other way, right? Too much exercise or, very restrictive eating or all of those things.
Right. But for the most part, that is the approach. If you're the average age of 43, 44, 45, considering egg donation, and you've had all these cycles where you couldn't exercise and where you were stress eating, sometimes you're in not the healthiest self.
Right. This is really helpful. I think all of these things are so important for everybody out there to listen to so that we can have a really good idea of what is reasonably possible for us and how to take the best care of ourselves possible. So, what do you think, if anything, we're missing here, Dr. Moomjy? Do you feel like there's anything that we haven't talked about yet?
No, I think that, sometimes it takes a village. We say that,
Mm-hmm.
right? I think that, trying to address your fertility early on is important because it will help you more likely achieve your last child. And addressing your fertility could be as simple as just coming in for a preconception consult with your partner and, just doing some basic testing and finding out what is your ovarian reserve, what's the pelvic anatomy and ultrasound, what does the semen parameters look like, what does the prenatal genetic screening look like? Like,
Yeah.
start early. Make a realistic plan. How many children do you want? When are you going to start trying? And give up, and accept the fact that each child is a 2 to 3 year journey because you need time to conceive, time to carry, time to
Yes.
breastfeed, time to recover. And so, as much as possible, try to have your family done by 39 if that is in any way possible. And if it's not, then consider banking embryos for your last child.
Yes.
I have to say, with more and more embryo banking, there is, in my practice, less and less of a need for egg donation. But people have to be proactive with their family planning and get the partner involved, early on because, men don't have to think about these things and they don't quite understand. But when men come into my office and they see the chart on aneuploidy, they're like, whoa, we got to make a plan. And I'm like, yeah,
Yes.
right.
Yes.
So I would like everyone to have that opportunity to do a preconception counseling appointment early in the committed relationship so that they have a realistic idea of how to, move through the next, 8 to 10 years and try to achieve their family goals. And some people, they settle down at a later age. And so even if you come for a preconception planning appointment, you get an idea of what we can and cannot do at which ages.
Mm-hmm. And even men, at some point, not to the extent that women do, but men also have a timeline on their sperm to some degree, right? And so even for them, banking embryos is helpful, right?
Absolutely. Absolutely. Their timeline is much more generous.
Mm-hmm. Yes.
That, again, they're often, making adequate sperm, well through their 40s up to about 50, but then certain neurological phenomena like schizophrenia can go up with paternal age.
Right.
So, there is a benefit to banking embryos for men and women, depending on what age they're starting and how big of the family they want, and taken into account that each child is a multi-year journey.
Yes. Yes. Or maybe more. Maybe many years. Yes. It's true. It's so true. Well, that's so helpful, Dr. Moomjy. I really appreciate you coming tonight and telling us really what we need to know. And I really hope everybody out there is listening because we plan ahead for so many things in life, right? We plan ahead for college or graduate school or medical school, and we think about where we want to be in X number of years, but not for our family in the same way. And hopefully that's changing.
Well, I always say that sex ed class you got in 8th grade was unfortunate because it made people believe that they could get pregnant with one missed condom.
Yes.
And when you're trying to conceive in your 30s, it really requires months of healthy living and good opportunities. And that to some people is shocking. So I would say
Yes.
that we really need a human reproduction 101 for everybody as they're graduating college so they can better understand how to plan for themselves.
Well, I think that this episode will help, Dr. Moomjy, because we'll
I
get it out
hope.
there to people. Yes. Well, thank you so much for your time. Where can people find you?
Well, I have a private office in Midtown, 60th and Park Avenue. And I'm here almost certainly 5 days a week. And I have a website, drmoomjy.com. And we are very, very responsive to patients. The whole goal here is to provide private care, reduce the stress, but also I work very closely with the NYU Fertility Center so that my patients have some of the best embryologists in the country working on their eggs and embryos. And so it's been a wonderful collaboration that really helps me provide a lot of private care for patients in this not so easy process.
But it's wonderful that your patients have you because you're so thoughtful and so kind. And I really appreciate all this great information. So thank you again. And for everybody out there, thank you for coming. I know that your time is so precious, but this is really important. You can spend lots of time on the internet, on websites, and all sorts of places getting information, and you won't get what you get here. So please come back again. And before you leave, press subscribe because that's how we keep going. I'll see you next week. Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.